100 days into the second Trump administration, the priorities and possibilities for health policy are coming into focus. What does it all mean for quality? I'm Andy Reynolds. Today on Quality Matters, the first of several discussions about recommendations to the Trump administration to shape quality's future. To begin my tour of these topics, I'm speaking again with Eric Musser, who told us about new federal rules for data exchange back in episode 7. Eric, welcome back. Please remind our listeners who you are and what you do.
Thanks, Andy. Great talking to you as always. I'm Eric Musser, Vice President of Federal Affairs at NCQA. I've been at NCQA for nearly 9 years and have spent most of my time working with state and federal agencies advancing healthcare quality.
Eric, you're the lead author of NCQA's recommendations to the Trump administration. We will link to those in the show notes, and I want to discuss them with you in just a minute. But first, by my math, your 9 years at NCQA cover all or parts of 4 presidencies: Obama, Trump 1, Biden, and now Trump 2. So as a public policy guy, give us your report from the front lines. What have the first 100 days of the second Trump administration been like for you?
I was joking with a fellow policy wonk a few days ago. The first 100 days of any administration can be painful and you might not like your job too much. Policy usually happens slow, but during the transition, it seems to come at you fast. When an administration comes in, they try to make their stamp in that first 100 days. And we're feeling that the way rules are coming out, regardless of who's in charge, creates a whirlwind of regulation and directives to read. So while we're formulating our own recommendations, we are trying to understand how the policy landscape is evolving. Where we see opportunity with this administration is to build off work that did get started in 2016 to 2020. The administration put out a bold mandate to move quality programs to digital quality reporting by 2025. When Biden took office, that mandate was walked back some and said sometime around 2030. Stakeholders are committed to a firm date. They're looking for and already investing in the technologies that will make that happen. We think that this administration, with their priorities, will be excited and encouraged to have the regulatory arm of the government support the move to digital, but also to bring some of the incentives, those industry incentives that are going to be needed to bring all stakeholders to the table.
Let's get into those recommendations. They focus on 3 main areas: value-based care, digital health infrastructure, and behavioral health. Now, those are 3 big topics, and I'm curious, as you were writing these recommendations, how did you think about linking them together?
We've been investing in behavioral health. We've been investing in the move to digital, and we have been encouraging value-based care arrangements. We have good progress to share about NCQA's work, but we also think that there's strong opportunity for this administration to help advance the ball with many stakeholders in American healthcare.
Let's get more specifically into the recommendations themselves. There are 3 of them. The first concerns value-based care, and that is value-based care models that prioritize care integration to prevent or alleviate chronic illness. Second major recommendation is in digital health. That's all about digital health infrastructure that facilitates data exchange, promotes adoption of digital quality measures, and supports data interoperability. Third, behavioral health. That is integrating behavioral and physical care and removing barriers to behavioral health and substance use disorder treatment. Tell me, Eric, how those 3 recommendations fit together. Is there some kind of hierarchy or sequence to them?
With the integrated quality care recommendations, we are trying to break down fragmentation. Folks feel as a consumer, care delivery models today are only doing what they're designed to do. And as a patient or a family member, having to manage various stakeholders and their processes and their policies built for their systems is the way we ended up in a situation where we do have incredible fragmentation. If you go to the doctor's office, you recognize how frequently you're asked to fill out your family history. We're seeing the opportunities to bring additional data together to say, how are we all working from a shared data-enriched care plan where we're helping people access the services, and then the team that's around that patient is getting that real-time feedback about how that patient is managing their conditions. Are they making it to their appointments? Are they getting to physical therapy? Where we are now, that all relies on the patient or the caregiver to make that happen. But with AI and where technology is taking us, there's an opportunity to redesign how care is delivered and help people manage their conditions long term.
Let's focus on the first of the three recommendations, how value-based care can support care integration. What's happening with value-based care and care integration that made you want to focus these recommendations there?
At the federal level, we have not seen the shift to value-based care in a way that has spurred 100% industry support. 100% is a lot to claim, but that's the system we need to build towards, particularly in MIPS, which is the merit-based incentives program for Medicare, and some of the other alternative payment models and value-based care arrangements. The burden of reporting has fallen to providers, and that burden has hindered the excitement of entering into value-based care arrangements. This administration is capturing advancements in technology to say there are better ways we can look at measuring competition, quality, access that aren't just providers logging on to a CMS portal and updating a measure rate or building off of legacy platforms. All of these things create fragmentation that doesn't promote this move to value-based care.
So the foe or the enemy is fragmentation.
The enemy is fragmentation. And there's both care fragmentation and data fragmentation. We're looking to make those things both come together to have better population health outcomes.
Tell me about those two species of fragmentation, please. Care fragmentation and data fragmentation. How do you see each of them?
On care fragmentation, it's what you experience as a patient. If you have chronic conditions, you are the quarterback for that care, and you might be spread across multiple providers, different networks. You're going to get explanation of benefits and member rights and responsibility packages. These things are cumbersome, and it's on you to understand how to manage the way in which you receive care. That's on the delivery of care and how you experience your health plan.
Okay, so that's care fragmentation. What's your take on data fragmentation?
The data fragmentation, there's data locked in EMRs. There's data on care management platforms never making it back into the EMR. HIEs, health information exchanges, are helping with public health reporting. That data is not standardized. We're encouraged about the work that's happened at the Office of National Coordinator, ONC, now ASTP. We're going to need to integrate the United States Core Data for Interoperability, the USCDI data set that's managed by the Office of the National Coordinator. It's the core requirements around what data needs to be accessible in the electronic medical record. We're building our measures to align to that core set of data elements. We're hopeful those policies will help ensure we don't have data fragmentation. We believe that the Trump administration will continue to be supportive of data standardization and interoperability. We're encouraged about the opportunity at ONC to leverage their electronic health record, EHR certification. That is a way we can ensure standardized clinical data that can be used in digital quality measure reporting.
What do you think most people get wrong or misunderstand about the need for care integration?
People think, well, we have systems and often folks have insurance. People have primary care doctors readily available. But if you look at the workforce, it takes 20 plus days to get in with a primary care doc. It takes months for behavioral health specialists. We need to help solve some of the workforce challenges. If we don't bring regulatory relief and if we don't provide the tools that help them do more with the data they're exposed to, we're just going to create more fragmentation. So when we create this integration, we need to understand that More isn't always better. Well, having more data will help us make more informed choices. It does feel like data overload. New tools that are coming to market should help simplify that to provide better care. There's so much data, but the quality of that data is extremely important. The emerging electronic health data can be used in population health. It has great potential, but has the need for ensuring data is being used for the quality use case, for the prior auth use case, for the care management use case in an appropriate manner. Without some guardrails around data, those things can be challenging.
Okay, you've outlined the broad strokes of what NCQA recommends regarding value-based care that prioritizes care integration. Let's get into some specifics on how you propose that the Trump administration do all of that. The first specific bit of advice says we urge the administration to expand the commitment to ensuring that all Medicare beneficiaries are in value-based arrangements by 2030. Should I read any significance or priority in the fact that that is listed first?
This is first because we're requesting they think about optimizing value based care arrangements and alternative payment models. In optimizing them, they could hit their commitment of moving all Medicare beneficiaries into value based care arrangements by 2030. We hope this administration will continue to look for ways to enhance what has been a slow crawl to value based care. This is an important milestone for this administration to recommit to moving these programs to meaningful value based care arrangements.
And are you recommending just a schedule change or a change in scope? In other words, are you only looking for an earlier deadline for switching to all digital reporting, or are you calling for something more?
You could accelerate by providing greater flexibility and incentives to optimize and perform well in those value-based care arrangements. You could also create value-based care incentives that drive adoption. The deadline, if you will, is a commitment to a value-based care roadmap to get there. Anybody who would make a statement like that recognizes the challenges of moving the entire Medicare program to value-based care. We don't make the recommendation lightly. It is a bold goal. We're supportive and have been supportive of CMS's vision for that, but there's real challenges. We're hopeful the evolution of the quality landscape will help models becoming more prolific.
That brings me to NCQA's next how-to tip for implementing value-based care that prioritizes care integration. You write, we encourage CMMI's new leadership to break from existing limitations and create models that prioritize integration through technology and dynamic care plans. What are these existing limitations that you would like to see broken?
CMMI has invested billions of dollars into testing different models. I believe only 4 made it in the national programs, which is the goal of innovation models. We need to empower this agency tests faster and in real time. The agency to date hasn't leveraged a ton of digital quality measures. They have a great opportunity to lead on interoperability. That is not something that has been a key focus to the Innovation Center. We're at a point where FHIR, which I know you've talked on the podcast about many times, Andy, the interoperability standard for exchanging healthcare data, is at a place where we can design reporting requirements for model participants where clinical data and administrative data can get back to CMMI in a way that they can update the programs for cost and quality improvement in a way they're not doing today. Data standardization and the movement of that data will empower both policymakers, but also those providing care with data that they can use at the point of care to help maintain the health of the population.
Eric, a term at the end of that recommendation jumps out at me. Dynamic care plans. What are they and why do they matter?
You have the ability to get data from a big data mentality where we can understand additional implications to what the doctor is able to see in front of them. Imagine a care plan integrating data from remote patient monitoring or more real-time access to lab data, dynamic care plans leveraging new technologies like artificial intelligence can integrate patient data faster to update care plans and ensure care is as good as it can be.
The next recommendation regarding care integration is NCQA suggests HHS prioritize more effective use of patient-generated data, including patient-reported outcomes measures. What do you mean by that, and how do you see that fitting within Trump administration priorities?
We know the Trump administration has a patient's first agenda. They put the consumer first in the way they think about quality and payment. There is a desire in the measurement space to have more measures centered around patients' goals. That's a person-reported outcome or a patient-centered outcome, as we call it here at NCQA. You want to make sure that the patient gets that strong clinical care. But the experience to ensure that they want to come back for that clinical care is also extremely important. So person-reported outcomes are about enhancing the experience of patients as they work with their care team. This is important for folks with chronic conditions, behavioral health, having those goals that are patient-centric, like walking down the stairs, getting to church, are all ways which improve health and then get that buy-in to the care plan that we're seeking to support.
The next suggestion is CMS should introduce one or more Medicare Advantage star ratings metrics that promote standardized data exchange between Medicare Advantage plans, their networks, and patients. Unpack that for me, please. What are you getting at there?
I think as an industry, we are getting to standardized data. We are getting to a place where it could be fluid, but data we need to be accessible for digital quality measurement has been stalled by business interests, leveraging the Medicare Advantage STARS program to include incentives for transmitting data between providers and payers to have a more real-time view on the population that they're serving is an important step forward. And whether it's in the Medicare STARS program, if it's in other regulation, there's value there to get over the barrier of business interests being the reason why data isn't being shared. There's opportunities for people to invest and see the value in sharing that with their partners.
Eric, what have I not asked you about value-based care models that prioritize care integration that you think people should know?
You can expect to see NCQA think hard about care bundles of measures, programs that support the integration of care that streamline requirements between value-based care at the payer level and at the provider level. That commitment from NCQA should help identify areas of need from a population perspective, but also figure out ways to wrap quality and patient safety into those arrangements. We look forward to leveraging new digital technologies to dream up measures and tools to help clinicians, payers, and others take care of fragile members.
I think that's a good place to leave it. We will link in the show notes to all three sets of NCQA's recommendations for the Trump administration. This conversation has focused on the first of those three, implementing value-based care that prioritizes care integration. We will devote separate podcast episodes to recommendations for digital health infrastructure and behavioral health. Eric Musser, NCQA Vice President of Federal Affairs, thank you for being here.
Thanks, Andy. Great talking to you as always.
Thank you for listening to Quality Matters. You can always learn more at ncqa.org. And be sure to subscribe to Quality Matters wherever you get your podcasts. We'll see you next time.